So I will now turn it over to our presenter, Dr. Christy Ward.
Thank you. All right. Hi, everybody. Let me share my screen here real quick. All right. Y'all can see that okay? Okay. So today we're going to talk about trans-inclusive cancer care. So just to go over some quick objectives. Our objectives for this session are to review the definitions and statistics important to understand transgender care, to discuss cancer prevalence, screening, and treatment in this population, and understand barriers to care in this population and how we can help. So let's just start with some definitions so we all know that we're on the same page and we're all talking about the same thing. So the first definition is going to be transgender. This is often abbreviated or shortened as trans. This is people whose gender identity is different from the gender they were thought to be when they were born. Non-binary is someone who identifies as neither a man nor a woman, or they can identify as a combination of male or female. AFAB is assigned female at birth. AMAB is assigned male at birth, and cisgender are people who identify with the gender they were thought to be when they were born. Gender identity is the internal knowledge of your gender, while gender expression is how the person presents their gender on the outside. Gender dysphoria is a psychological distress resulting from incongruence between one's sex assigned at birth and one's gender identity. And gender transition is when a person begins to live according to their gender identity rather than the gender they were thought to be whenever they were born. So approximately 1.1% of the US population identifies as transgender, these people who self-identify as transgender. An additional 1.5% identify as none of these. This might be some version of non-binary or some other identification other than being a cisgender male, a cisgender female, or being transgender. So in West Virginia, 0.4% of our state's population has been identified as self-identifying as transgender, which is about 5,700 of the state's population. Now, it's thought that this is probably not less than the rest of the United States. It is probably just people are less open about identifying themselves as transgender. So the statistics in West Virginia probably approach the United States, but for reasons, patients or people may not feel comfortable identifying themselves, especially in these statistics. A really big thing that we worry about whenever we talk about trans care is going to be suicide. Up to 78% of trans college students have reported some kind of mental health issue, and 32 to 50% have attempted suicide. I mean, this is a huge issue in this population. These people face gender-based victimization, discrimination, bullying, violence. They can be rejected by their family, friends, and community, harassment by intimate partners, family members, the police, and the public. And they also fear discrimination and ill treatment by us as healthcare providers in a system. And these really impact the suicidal and the mental health issues in the transgender population. So a lot of things that people who can do whenever they're trying to show their gender expression fall under gender affirming treatment or care. Gender affirming is helpful for suicide prevention, for mental health. It is healthcare. There's hormone therapy, which is going to be abbreviated GAHT. That can either be testosterone for someone who is assigned female at birth, who is transgender male, or estrogen therapy for someone who is assigned male at birth, who is transgender female. Different surgeries to make their outward appearance more like their inward appearance, facial hair removal, interventions for the modification of speech and communication, and different behavioral adaptations such as genital tucking or padding, chest binding, or other things to help them with their gender expression. So now we'll go into a little bit about cancer risks and cancer prevalence in the transgender population. So this right here is, of course, a graphic of a lot of the identified lifestyle risk factors for cancer for all of us in the population. Among patients who are transgender or non-binary, they can have a higher rate of smoking and a higher rate of obesity. In trans females, it was shown they have a decreased amount of physical activity. Non-binary persons might have a higher alcohol use, and there is a higher rate of viruses such as HIV, HPV, HBV, and HCV among this population. However, whenever we actually look at the cancer prevalence, there is not a whole lot that is studied in transgender people. There's actually only about 3 major studies that have focused on cancer prevalence among this population. Whenever we look at the prevalence among this population, there's no significant difference in the cancer prevalence between trans individuals after starting gender-affirming hormone therapy and cisgender individuals. Trans men had a significantly higher prevalence compared with cis men, so similar to that of cisgender women. So trans men who are assigned female at birth have a cancer prevalence that is closer to cisgender women. The cancer prevalence among transgender women and gender nonconforming individuals approaches that of cisgender men and cisgender women. So overall, the population experiences a prevalence of cancer and incidence of cancer that is more similar to the gender they were assigned at birth. Cancer screening is a big issue in this population because there are no specific screening guidelines for transgender individuals. Whenever you look at so if you look at like the American Preventative Task Force, it specifically says things like breast cancer is breast cancer screening in women, cervical cancer screening is cervical cancer screening in women, prostate cancer specifically mentions men. So transgender patients can really have difficulty relating to gendered guidelines if they don't identify with the gender that is specified in the guideline. So one thing we want to do whenever we talk to patients who are transgender is we want to focus on the organs that are present in the patient. So a person who is transgender female likely still has a prostate, and there's some things you need to do to evaluate for prostate cancer if they choose to do so. People who are transgender male may or may not have breasts or cervices or other things that need screening. So it is important whenever you're using your language and in counseling these patients to focus on the organs that they have and remind them that they still need screening and that we still want to give them care for these things. So now let's look at some of the hormonally related cancers. So breast cancer, of course, is going to be one of our most common. The incidence of breast cancer, cisgender men is less than transgender women. So these are people who are assigned male at birth. This may be due to increased exposure to female hormones. Transgender men who are assigned female at birth have less of a risk of breast cancer than cisgender women. And this may be because of either the surgery for having the breast removed or if they are getting testosterone. So it's about 4 in 100,000 person years in transgender women and 6 per 100,000 person years in transgender men who have been taking estrogen or gender affirming hormone therapies for greater than 5 years. So transgender women undergoing gender affirming hormone therapies appear to be at higher risk than cisgender men. So this is transgender women who are on estrogen type therapies. Transgender men appear to have a higher risk of breast cancer compared to cisgender men. And this is likely related to the fact that they still are going to have more endogenous estrogen than someone who is male at birth. Transgender men have a lower risk compared with transgender women, and this is likely because of estrogen-containing hormone use. Sorry, not estrogen-containing, testosterone-containing hormone use. That's an error. So whenever we look at trans women, the breast cancers are typically treated, gender affirming therapy is going to be estrogens and then anti-androgens. There are no studies looking at transgender patients and breast cancer whenever we're looking at hormone therapy. So everything we're using is extrapolated from the Million Women Study, which is that very large study that looked at hormone replacement therapy in people who were born and identify as females. So in the Million Women Study, there's a correlation between hormone replacement therapy and increased breast cancer risk in postmenopausal cisgender women. And this seems stronger in cisgender women who use hormone therapy for greater than 10 years. And it's higher whenever it's used in a combination of estrogens with progesterones. So whenever you look at your trans women, we are only calculating their risk of increased breast cancer based on what we're extrapolating from cisgender women. So now whenever we're looking at gender-forming hormone therapy and breast cancer in trans men, exogenous testosterone causes a reduction in the glandular and adipose tissue and increasing the connective tissue in breast. The protective effect of testosterone has been shown to reduce breast cancer incidence in pre- and postmenopausal cis women treated with subcutaneous testosterone. But in estrogen receptor negative breast cancers, androgen receptors may play a role in tumor cell proliferation. So while this hasn't been shown because there hasn't really been any studies on it, there might be some concern in patients who have a estrogen receptor negative breast cancer and are on testosterone. So breast cancer screening, we already mentioned the difficulties with just the verbiage that we use in our breast cancer screening. In transgender women who have received gender-affirming hormone therapy, so this is estrogen derivative, same recommendations as for cisgender women, taking into consideration length of hormone use and dosage. So people who have been on hormones more than 5 years, their risk is going to start approaching that of a cisgender woman. So make sure that they're getting their appropriate screening. And then transgender men who do not undergo mastectomy, the recommendations are the same as for a cisgender woman. Whenever we look at gynecologic cancers, transgender men may still have the risk for gynecological cancer after gender-affirming surgery. Cases of endometrial, ovarian, and cervical cancers have been documented. Depending on what has been removed during surgery, there are still some spontaneous GYN cancers that can evolve even after removal of organs. Testosterone therapy has been hypothesized to increase the risk of hormone-responsive endometrial and ovarian cancers because they've been converted to estrogen. Although the studies are conflicting, so that's just a theory that we want to watch on. Trans men have lower cervical cancer screening than amongst cis women. So cis women about, sorry, 1 second. Sorry. So cis women approach 90% for getting their cervical cancer screening, whereas trans men only approach 70%. So they still may have risk of HPV and cervical cancer, but may not be getting the screening for it. So like we said before, make sure you're focusing the organs that they have and not the gender that they're presenting as. Gender-forming hormone therapy in gyn cancers, more. So based on data from the 2015 transgender survey, only 8% of trans masculine respondents underwent hysterectomy with bilateral salpingo oophorectomy. So this means that most transgender men still have their internal female organs. So they still have their uterus, their ovaries, their cervix. But around 70% of them are receiving gender-affirming hormone therapy, so some form of androgen. So now let's look at different parts of the GYN organs. So we're going to look at endometrial cancer, which is going to be the inside of the uterus. And in vitro models, androgens may exert an anti-proliferative effect on endometrial tissue, so shrinking down the tissue. But observational epidemiological studies show a positive association between serum testosterone levels and endometrial cancer risk in postmenopausal cis women. Because aromatase converts our testosterone to estradiol, so this could lead to proliferation in endometrial epithelium. Now moving on lower down to the cervix, cis women who receive testosterone treatment have an increased, this is ovarian cancer. Cis women who have an increased testosterone treatment had increased ovarian cancer risk. The complete cause of that is not known, probably the same thing with the aromatization of the testosterone into estrogens. And then going down to cervix, high levels of testosterone may be associated with invasive cervical carcinomas in cis women. All of these are, as you see, they're maybes. They are not definitive. These studies showed very small associations. So what do we recommend for screening? Like we said, there are no actual official guidelines, but what we recommended for transgender care is in transgender men, the same recommendations as for cisgender women if they still have the cervix. Risk, transgender men do not have a lower risk for cervical abnormalities compared with cisgender women. Anal cancer screening. Transgender individuals who engage in receptive anal intercourse should be considered for anal Papa Nicolau testing. Risk for anal cancer, HIV positive status, and sexual practices such as receptive anal intercourse are risk factors for HPV-related anal cancer, so they should be screened as appropriate and as per the CIS population. All right, now we'll move on to prostate cancer. So gender-affirming surgery does not commonly include a prostatectomy. So even whenever converting male genitalia into female genitalia, the prostate is usually not removed in these surgeries. So cancer may have started developing before even the initiation of gender-affirming hormone therapy. Androgen deprivation is a common treatment for prostate cancer, and its protective role is described, whereas the effect of exogenous estrogens on prostate tissue is unclear. Some researchers suggest that estrogens maybe stimulate the prostate carcinogenesis through activation of ER alpha receptors, although ER beta is probably anti-neoplastic. So compared with cisgender men, transgender women have a lower prevalence of getting their PSA screening, so 32 versus 20%. So recommendations for prostate cancer screening in this population based on those two studies down below. Transgender women who have a prostate should have the same recommendations as for cisgender men. After vaginoplasty, so if they've had gender reaffirming surgery and have had a neovagina created, digital rectal exam may be unable to examine the prostate. So they recommend that checking a PSA is a better screening test than digital rectal exams, as the vagina may be interfering with feeling the prostate. A serum level of PSA of 1 nanogram per milliliter should be considered the upper limit of normal in individuals getting gender-affirming hormone therapy. Long-term gender-affirming hormone therapy could potentially select more aggressive or castration-resistant clone cells. So this should be evaluated, and PSA should definitely be checked. So now we'll move on to cancer treatment. Sorry, all of this gets a little dense with all of the verbiage and the hormones, but we'll try to get through it. So whenever we're looking at the implications of gender-affirming hormone therapy following a cancer diagnosis, there's potential adverse effects of gender-affirming hormone therapy related to drug-drug interactions, thrombosis risk, and hormone-sensitive malignancy. However, these risks are extrapolated from the cisgender population or from preclinical studies, so there's no, again, good studies looking at this. When there's clear evidence that exists, so such as someone who's taking exogenous estrogen in a trans woman with estrogen receptor positive breast cancer, you really have to weigh this against the psychological and physiological benefits of gender-affirming hormone therapy alongside the stage of malignancy and the treatment intent. So in all cases, this needs to be shared decision-making with the patient and all their healthcare professionals through a multidisciplinary team approach. So we need to acknowledge the extent and strength of the evidence, because honestly, the strength of the evidence is a lot of times not very great. So we need to consider if we would inhibit hormones for a cisgender person in the same circumstance. If we would not inhibit the hormones in a cisgender person, you probably should not be removing their gender-affirming hormone therapy. There are a lot of specialist services that are available. So we can look up different organizations that can help our pharmacy team and other people to help figure out some of these things. So just going over some of the potential drug interactions with chemotherapy that we need to think about. The metabolism of estrogen and progesterones is through the cytochrome P450 family of enzymes. We know a lot of our chemotherapies and therapy drugs are also metabolized through this. So this could affect the bioavailability of your drug or the bioavailability of your hormones, and should be monitored along with pharmacy. Potential interactions should be checked in a formulary and with our specialist pharmacist, and more frequent monitoring may be indicated, at least during the initial phases of a new treatment. Another thing we need to think about whenever we are giving chemotherapy and hormone therapies to these patients is that we often use the creatinine to estimate our GFR to be able to calculate our chemotherapy or therapy doses. And the GFR is based on muscle mass, and so it's going to be based on it's different based on gender. So trans patients on masculizing hormones have a rise in their serum creatinine within 6 to 12 months of commencing testosterone due to an increase in muscle mass. And trans patients on feminizing hormones have the opposite effect. So the constant use of the formula should be determined by the length of gender-forming hormone therapy, so more or less than 6 months, and the degree of the change in the muscle mass. Particular attention is needed if the individual commences gender-affirming hormone therapy while undergoing chemotherapy. If there's concerns that an accurate GFR cannot be measured, this can be measured by the 51 CR-EDTA clearance. And this is something that probably you can talk to the pharmacist and talk to some specialists dealing with gender affirming care to try to help with estimating kidney function if there's really concern about dosage of medications or possible side effects. Altered liver function. The liver enzymes can be observed to go up during initiation of estrogen and testosterone because they are metabolized by the liver. So the clinical significance of this is unknown. Changes to liver function in trans people with cancer outside of this period are more likely to be a complication of cancer or anti-cancer therapy, and it's rarely necessary to stop their gender-affirming hormone therapy, but you can continue to monitor these liver functions. We all have parameters of what we do for our chemotherapy, our other therapy, for deciding if the liver function is too high. So just continue to monitor all of that. So concern for thrombosis of feminizing gender-affirming hormone therapy. Studies the active cancer and chemotherapy are already known risk factors for VTE, as is feminizing gender-affirming hormone therapy. VTE rates are lowest using transdermal estrogen formulation, and there should be a shared decision-making with the patient about the possibility of switching from oral hormones to transdermal hormones. And if it's decided that a dose should be reduced, there should also be shared decision-making about that. In masculizing gender-affirming hormone therapy, studies showed that the rate of VTE is comparable to cisgender hypogonadal men using testosterone. Studies in cisgender men have shown a slightly increased risk of VTE in the first 6 months of testosterone. So clinical vigilance is advised within this first 6-month period with the option to use prophylactic anticoagulation in high-risk individuals. So looking at breast and prostate cancer and talking about the choice of therapies and what to do with gender-affirming hormone therapy is very complicated and probably something that we can't get into completely within this hour. I have put this reference up here by Dr. Berner, the best with the article number. They have a really good guideline on whether you should stop or taper and the decision you should make depending on the type of cancer, the receptor positivity, and the need for anti-hormone therapies. So I'd recommend looking at that resource to continue with that. If a patient's cancer management plan involves surgical management and it is appropriate, surgical management of cancer should consider gender-affirming surgery if appropriate. So if you're treating someone for breast cancer and they desire mastectomy as part of their gender-affirming surgery, that is appropriate. If they have a GYN cancer, it may be appropriate to continue with full hysterectomy and oophorectomy. In ways that you can combine these surgeries, it is appropriate and should be considered. So now we'll move on into barriers of care. Okay, we're going to skip that one. So when we talk about barriers to adequate healthcare among the transgender community, They face things like challenges to finding healthcare providers who are knowledgeable about and sensitive to trans identity and health issues. These and other barriers contribute to this population's underusage of healthcare services and in turn their poor overall health outcomes compared to the general population. So the first barrier is going under experiencing violence or discrimination in the community and the medical setting. This can cause fear, avoidance, depression, anxiety, and substance use, decreases their cancer screening, clinic visits, and identity disclosure. So they may be hiding things from their healthcare team. They may experience occupational discrimination, which increases risk of unemployment and poverty, which creates a difficulty getting health insurance, which means they can't get their cancer screening at their clinic visits. And then on our side, lack of provider competency and services increases their fear and their desire for avoidance, and it creates distress. This is going to cause patients to not seek us out for cancer screening, clinic visits, and decrease overall their quality of care. So looking at studies in transgender adults, 2 in 3 transgender adults worry that their health evaluations are affected by their sexual orientation or gender identity. You'll see some of the questions down there. Nearly half of transgender adults report having negative or discriminatory experiences with a healthcare provider. And more than half of transgender adults have avoided needing medical care due to the cost, due to poverty, lack of insurance. Even when care is accessible, it's often not equitable, especially for transgender patients. So one survey of medical students found that 95% were comfortable caring for lesbian, gay, or bisexual patients, but only 70% were comfortable caring for transgender patients. And only 1 in 4 was confident regarding the health needs of what transgender patients needed. More concerning, among oncologists working at a National Cancer Institute designated comprehensive cancer center, less than 40% were confident in their knowledge of the healthcare needs of transgender individuals. Inclusions of transgender health and medical and nursing school curricula and continuing education is a crucial step forward in moving forward for care of our transgender individuals with cancer. If you think about it, I'm sure you'll notice that we tend to have binary management in healthcare. We tend to apply a male-female lens to much of healthcare. In a lot of our research, we split out male and female. A lot of our research only has male or female. Looking at a study from a European Society of Medical Oncology report, they recommend to consider men and women affected by non-sex related cancers as biologically distinct groups, so even making it more binary. And this raises the questions of how do we treat and study trans patients when we have this dichotomous framework and we don't have set up how to handle more than 2 sides. As a gynecologic oncologist, it can be I see that it can be really difficult for these patients to come in and get care from the gynecologist. They can face additional barriers to gynecologic care with discomforts with their female sex organs, the need to disclose their transgender status, and fear of receiving a gynecologic examination. The fears may lead to delayed diagnosis and worse health outcome. This can be addressed apart by increasing our provider awareness and normalizing a broad range of patient backgrounds. Like we talked about, they may be uncomfortable with terms like women's health because they don't identify as women. The fear of the gynecologic exam is something I see in a lot of my patients. They may have trauma in their past, or it may bring up things like reminding them of how their genitalia doesn't necessarily match how they feel inside. So additional barriers that patients can face is our lack of usual source of care, our cost. They are often misgendered and feeling that they have disregard for their health concern. They're uncomfortable with gender-labeled services and feel that there's a lack of attention to patient-centered care. So things that we can do is looking at our intake forms, which is really good for us here in the Cancer Center. We can use these forms to help gather information about names and pronouns and what patients would like to be referred to and what they feel comfortable with. They suggest that not just having the male, female, or male, female, other box, but to maybe actually have a blank space where they can write in their preferred gender and their preferred pronouns. In a situation in which a gender pronoun or name mistake has been made, the participants noted that an apology or correction to the mistakes are helpful for overcoming any negative reaction to this error. Do not make excuses. As unfortunately has happened to me several times, I get into the being really used to saying she and her and talking about females, and have unfortunately misgendered my binary and my trans male patients. Don't make excuses. Just stop and say, I'm sorry, I used the wrong pronoun, and just move on and try to be more cognizant about using the correct terminology. These changes can be really difficult at first, given that we are very gendered in our language, and it's very ingrained in our healthcare system and how a lot of us were taught. So it is a conscious effort every day for us to continue to try to be more inclusive for these patients. Another problem with the knowledge is that participants felt burdened in this study. They felt burdened by what perceived as an expectation that they could educate their healthcare provider about trans issues. So patients don't want or feel anxious and don't want to come in and have to educate their doctor or their nurse or their nurse practitioner about health issues that they feel that their provider should already understand. Whenever you meet a patient, if you don't have existing knowledge about something, make sure that you let the patient know, I am not very familiar with this, but I will look it up. Let them know if any prior experience that you might have, if you feel this is pertinent to the conversation. And do not rely on the patients to educate you, but learn where the reliable resources are that we can go through and learn what we need to learn to be able to take care of these patients. Many trans people encounter healthcare providers who ask inappropriate questions regarding their trans identities or their bodies, or questions that are relevant to their care. So be careful asking questions just for curiosity or to try to make conversation. Make sure that you are being sensitive in everything that we talk about. Remember that these patients experience a disproportionately high rate of harassment and violence, and this can cause them to avoid or feel reluctant to pursue healthcare because they don't want to be touched or exposed in a physical examination. Trans patients need to be made to feel comfortable when undergoing physical examinations to ensure that they will continue to come back and access their necessary screenings and their treatments. So things that we can do in the examination room to try to help. So first, ask the individual if there's certain terms they prefer for their sex organs. Like some patients don't like their breast being referred to as breast. They prefer to it referred to as chest. Provide a thorough explanation of the importance of the procedure and detail what is going to happen throughout. So kind of get a rundown of what you're going to do. And I recommend before doing anything, stopping and doing it and asking permission for things that are invasive. Make sure you're getting, like I said, make sure you're getting consent before touching them in new locations. Ensure that they feel welcome and comfortable. Make sure that they stay adequately draped throughout the examination to protect privacy. So that's, draping materials, that's gowns, that's allowing them to stay in their clothes when they can. That's if we're using instruments, make sure the instruments are as warmed appropriately, to tell them if there's an instrument that that's going to make noises or smells or other things, just to make sure to warn them because they're already a little bit on edge. So we want to do everything we can so they can anticipate what we're doing and be less on edge. Accommodations that we should consider is consider having a private room as opposed to sitting in the common waiting room. This study looked at trans men who were pursuing gynecological care. A lot of them felt more comfortable when they were offered the opportunity to sit in a private room as opposed to just sitting in a common waiting room that was just women. Things like staying in their clothes while they're waiting. Another participant was talking about waiting for an x-ray and was told that they could stay in their clothes rather than having to go into a changing room, change into a gown, and then sit into a common waiting space with other patients while wearing a revealing gown. These accommodations should be offered, but they are not required. So if a patient is fine with sitting in the waiting room or fine with going into the common changing room, they don't necessarily have to be made to have these accommodations. Just know that they're available. It's also important that when you're making these accommodations, you're making it in a thoughtful way because you want to make sure that you are not making them feel like they are being excluded or you are outing them in any way. So inclusivity, trans individuals appreciate when their healthcare providers are supportive, compassionate, and understanding, just like all of our patients do. As our knowledge and experience with trans patients increases, this is going to improve our attitudes and our perceptions of trans people. Our healthcare providers and healthcare organizations and educational institutions should take the time to learn about trans health identity and health issues and implement steps to demonstrate our knowledge and our sensitivity. And we need to focus on our curriculum to include transgender health in medical and nursing schools and continuing education in those of us who maybe didn't get this in medical and nursing school. This is going to be really important to continue to improve care for transgender individuals with cancer and with all issues. So just to summarize some of our most important points, as healthcare providers, we need to educate ourselves about this population. It's not their job to educate us, it's our job to educate ourselves. Overall, there's a lack of epidemiological evidence showing a relationship between receipt of gender-affirming care and cancer prevention treatment, highlighting the need for more research. So make sure that you're explaining this to the patients, what we are basing our recommendations on, and acknowledge that there is not a lot of evidence that is focused on this population. Although many cancer treatment are hormone-based and may interact with gender-affirming hormone therapy, most transgender patients are not counseled about potential issues and clinical guidelines are lacking. So whenever we're considering changing or altering anything to do with their gender-affirming care, we need to be very cognizant and very careful to have a risk-benefit discussion with these patients and make it shared decision-making to decide what we need to do. And in addition to this shared decision-making, it should be with the patient and with a multidisciplinary team. This may include us, our nurse navigators, our pharmacists, anyone who has insight into how these things interact. And if a patient decides that they are not comfortable avoiding their gender-affirming hormone therapy, this should be acknowledged that we've discussed the risks and benefits and discuss how you should continue to manage this. And one of the things we especially don't want to do, because a lot of these patients don't necessarily get their gender-affirming hormone therapy from doctors. They are getting it from other people in the community, and we don't necessarily want them to go out after the decision has been made to stop this medication to go get it and not be telling us what they're taking. So we want to have open and honest communication on all sides. Surgical and hormone treatment should be evaluated to see if they can include gender-affirming care. So like we talked about, if there is surgery that is appropriate but can also help affirm their care, then look into that. And trans individuals face many barriers to care, and we as healthcare providers should not be one of them. These are the references that I used for this talk, which is honestly most of the literature that's out there, because like I said, there's not very much. And I appreciate all of y'all being here and making this step towards continuing to make WVU medicine and cancer a inclusive and a welcoming space for all.
Thank you, Dr. Ward. We'll now open it up to questions. So you could either put your question in the chat, or you can feel free to take yourself off microphone, open up your microphone and ask your question individually. We do have one question in the chat. I'll ask, Lori, you put that in there. Would you like to ask it, or would you just like us to read it for you?
No, I'd love to ask it. I just didn't know what was going to happen. But so I was just wondering for Gardasil, I know the age sort of cutoff is 45. Is
Yes.
there a reason that you couldn't are there enough data to support not, it not being effective or loss of effectiveness or just statistical ineffectiveness after 45?
No, it's just the population that was studied.
Oh, okay. So so
Yeah.
it would be okay if somebody came to you and said, you know, I'm active, I have active whatever, and I still want to have the Gardasil vaccine. You could still provide it for them.
You can, just insurance probably will not cover it when it's outside
Of
of the,
course.
and insurance doesn't cover it for, I mean, they cover it for prevention, but they're not going to cover it for, we can't say that we're doing it to try to help with their HPV infection, but we are starting to get some evidence that it may actually be causing a little bit of an immunological response that may potentially help infections that are there. So
Oh, that's
probably not a
great.
huge bit, and it definitely helps protect against the other HPV viruses that they don't already have, because everybody has HPV. It just depends on the type you have.
Great. Thank you so much.
Of course.
Your talk was amazing. Thank you.
Well,
Everybody should get that talk.
thank you.
Thank you.
Are there any other questions that we have today? As I said, you can feel free to put it in the chat or just ask it in person. And while we're deciding if anyone else has any other questions, I did want to share that the Mountains of Hope Cancer Coalition, which helps to co-sponsor this Project ECHO series, has been doing some work where they took the National LGBTQ Cancer Network. They had a community health needs assessment survey. And so the coalition has worked with them to adapt the survey for use here in West Virginia. So the survey is out. I just realized I'm talking and I'm on mute. Apologies for that.
We can hear you.
Could you hear me?
Yeah. I mean, I
okay.
could, but I don't know if anybody else could.
Okay. So I was saying that the Mountains of Hope Cancer Coalition is partnered with the National LGBTQ Cancer Network to adapt their community health needs assessment survey. So that survey has been out. It is going to close at the end of this month. We are trying to get responses from every county within West Virginia and have been doing really well with that. I think we've got about 9 counties that we still have not received responses from. So I did put the link to the survey in the chat. If you know of anyone or would like to help to share this information to help us, get a really good representation across West Virginia, we would greatly appreciate your help with that. And Jenny has also put in the chat that if this is your first time and you're wanting to get continuing education credits, there is a registration form we're going to ask you to fill out. Any other questions for Dr. Ward? Okay, well, thank you very much, Dr. Ward. This was a wonderful presentation, and we really value and appreciate your time today.
Thank you.
Thank y'all. Have a good day.
Thank you, everyone.